Hello everyone. Today in this video we are going to discuss management of dengue fever in a pediatric population. This is very much important for the practical purpose. Why? Because there is a plenty of changes in recent guidelines of management in dengue fever for the pediatric population. So we have to know all the changes for the management of dengue fever in pediatric population, as well as we have to know what is the proper management of a dengue shock syndrome, because if we cannot treat severe dengue according to the management protocol, then the child will having some problem. So we have to know each and every step very elaborately and carefully. So let's start with the cause of dengue fever. First, as we know, dengue fever is caused by the virus, that is dengue virus. And dengue fever is an acute self-limiting illness caused by dengue virus, and which is characterized by fever, myalgia, arthralgia, and rash, just like other viral fever. And this dengue virus are having four serotype. So the four serotype are DN1, 2, 3, 4. So these are the four serotype, among which any of the serotype can cause dengue fever. This dengue virus is an arbovirus, and this is belong to the family of Flaviviridae. All are the MCQs, and the vector for the transmission is the Aedes aegypti mosquito and Aedes albopictus mosquito. So these are the main vector for the transmission of dengue fever, and this mosquito is transmitted this virus from human to human and also from mosquito to mosquito. And after infecting, after taking the blood of an infected patient, the virus present in the mosquito and for a incubation period of 8 to 10 days. After this period, the mosquito is become infected, and this mosquito can infect other human being. So the incubation period is 8 to 10 days for dengue fever. Now dengue fever is just like a normal other type of viral fever, or sometimes this dengue fever may present with some severe complicated problems. So how and why normal viral this dengue fever becomes so problematic, other than the normal viruses, we can know, we have to know the pathophysiology of this. First, the clinical manifestation of any dengue fever. So, in classic dengue fever, there is a presentation of a fever, and the fever is high grade fever, and this fever is last for more than 5 days. So, there is a fever is high grade fever, and this fever is high, mainly last for 5 days, and along with there is a retroorbital pain. And just like other viral fever, there is a presence of myalgia, and there is a arthralgia is also present, and there is a severe joint pain which is called breakbone pain. And just like other viral fever, there is a presence of rash, but there is a typical finding of this rash. This rash is mainly present 3 to 5 days after the fever. This is normal rash in case of classic dengue fever. This rash which is now telling, it is in case of normal classic dengue fever. But another rash is also seen, which is mainly present in the afebrile phase. I will discuss on later on. But the classic rash in case of dengue fever is mainly present in the 3 to 5 days after the fever. And this rash is having features of diffuse flushing, mottling, or splitting pinpoint eruption, mainly present on the face, neck, and chest. And this maculopapular rash mainly starts in the chest and then spread to the extremities. So this typical rash may present 3 to 5 days after the fever start. Now the dengue fever is presented with different clinical manifestation. As I say, this is a virus. Dengue virus may present with normal viral fever. That means this dengue fever may present as asymptomatic just like other viral fever, or this dengue fever may present with just like undifferentiated febrile illness, just like viral prodrome, that means normal fever and runny nose, diarrhea, just like that. And other type of presentation is the dengue fever may present with classic dengue fever, that means as I say, fever for high grade of fever more than or normally 5 days, up to 5 days, and there is a severe back pain, that means breakbone pain or joint pain. There is a retroorbital pain, rash, along with myalgia, arthralgia. And after 5 to 7 days, the fever is subsided, and the child may just not present with normal child. And the last and the most important and classical type is dengue fever may present with shock and hemorrhagic manifestation. Previously, it is said that dengue hemorrhagic fever with shock or without shock. Now the name has changed, and the name is severe dengue. So the patient may present with severe dengue. That means the patient may having three features. Any two of the three features. That means may patient present with shock, coagulopathy, and lastly present with increased fluid overload. So this is called severe dengue. So the child may present with asymptomatic or normal viral fever or classical dengue fever or just like severe dengue. So now we'll discuss how the severe dengue fever occur. Now, what is severe dengue? That means there is a presence of either shock, bleeding manifestation, or coagulopathy. So normal viral fever is normally present with does not present with shock, bleeding, or coagulopathy. But why this simple virus can cause this type of severe problems? We have to know the basic pathophysiology of this. So before knowing the pathophysiology, we have to know how and when this any patient may lead to severe dengue. So suppose this is the dengue virus, and this virus is causing any problem to a patient by the strain of dengue virus 1. That means one subtype is enter first time to the body, and the antigen presenting cell APC is seeing that this is a antigen, and this virus is engulfed by the antigen presenting cell. This virus present this antigen presenting cell too, as this is a virus, and this is killed by the T8 cell, that means CD T8 cell, and this APC cell present these viruses to CD8, that means T8 cell, and this T8 cell and also stimulate the CD4 cells, and this CD4 cell is present stimulate the B cell, and the body produce plenty of immunoglobulin against the this antigen, and that means there is a stimulation of CD8 cell, that means T8 cell, and there is also stimulation of the CD4 cell and B cells. So T cell and B cell is stimulated by the one, that means dengue virus 1. So and this immunoglobulin firstly present with IgM, after that it changes to IgG, and this B cell producing some memory cell. So this memory cell keep memorizing the strain of this antigen. Now this same patient is now present again infected by dengue fever and dengue virus, and this now the strain is 2. So this antigen is again presented by the antigen presenting cell to the T lymphocytes and also the B CD4 cell and also the B lymphocyte. And this B lymphocyte and T lymphocyte is thinking that this is some similar antigen, and they are produce huge amount of stimulate the huge amount of this T cells and CD4 cells stimulate this too much of macrophages, and also they stimulate the production of immunoglobulin. So huge amount of macrophage, huge amount of immunoglobulin is released, and these huge amount of macrophage stimulated macrophage now enter into the blood, and this activated macrophage now producing huge amount of cytokines, and there is a cytokine storm. But these cytokines cannot kill the antigen. That means this DS2 virus. Why? Because this virus is not just like DS1. So they cannot kill the virus, but they continuously getting stimulated by the antigen presenting cell, and this they produces plenty of inflammatory product, and the inflammatory product are interleukin alpha and interleukin and interferon gamma, and also interleukin 6 1, this type of interleukins, and these huge amount of cytokine storm is making the plasma leaky. So they destroy and making the plasma blood vessels leaky, and because of the leakage of the blood vessels and because of the huge amount of cytokines present in the blood, and this causing leaky blood vessels, destruction of the blood vessels, and all the fluid is getting out from the blood vessels, and so there is a so due to decreased amount of the fluid in the blood vessels, the blood pressure getting low, so the patient may present having shock. Second is the as there is a huge leakage, so the hemoglobin getting concentrated, that means there is a increasing of the hematocrit. So hematocrit getting increased, the patient may having presence of shock, and these cytokines is also, and this immunoglobulin, huge amount of immunoglobulin antigen, this antigen having some more similar mimical molecular mimicry of normal platelet. So this huge amount of immunoglobulin now kill the platelet, and there is a smart thrombocytopenia. So platelet count getting decreased, there is an increased amount of hematocrit, the child is in shock, and there is a varying degree of bleeding as because of the thrombocytopenia, and also there is a coagulopathy DIC. Why coagulopathy is there? Because of the huge amount of production of immunoglobulin, the body is also produces decreasing the production of coagulation factor, and also there is a huge amount of cytokine storm which decreases the which destroy the coagulation factor, and so there is a coagulopathy, and that means the child may is present with bleeding manifestation. So this is the main pathophysiology of the severe dengue fever. That means first time if a patient is infected by dengue fever, the patient may not less chance or slight chance of getting enter into the severe dengue fever features. But if the patient having dengue fever for more than one time, then the patient may present with severe dengue fever. So keep it in mind. Now the clinical phases of severe dengue. So severe dengue having three clinical phases, that means febrile phase. This phase is last for 3 to 5 days. That means there is a presence of high grade of fever, as I say. Now after the fever getting decreased, the child enter into the critical phase. Why critical phase? That means there is a huge leakage of the blood vessels, and there is a destruction of the blood vessels. The patient may present with shock. This critical phase is last 1 to 2 days, and these 1 to 2 days is very much important for the monitoring. So if any patient enter into shock in this period and we cannot treat the patient or cannot monitor the patient enter into the shock from compensatory shock to decompensated shock, child will having some lethal problem, and after 1 to 2 days the patient is recovered from the cytokine storm, and the child is entered into the recovery phase, and all the leaky blood vessels getting repaired and all the fluid getting enter into the blood vessels, and no leakage of the blood vessels, so fluid is in much more, and the child is present with normal features. So this is the three phase. Now this picture shows that the febrile phase, that means first 3 to 5 days, the temperature getting high, and the patient also having no other symptoms, but there is an increased amount of viremia. So in this phase, if we do NS1 test, the NS1 test is positive, highly positive. So for this, for the first 5 days, we have to do NS1 test. After the febrile phase is over, the patient enter into the critical phase. That means there is a cytokine storm is there. All the blood vessels are getting leaky, and there is a patient is present with shock and bleeding or organ impairment. After this critical phase getting over, that means for the next 2 days, if the patient is survived by the patient gets survived the critical phase, then the child enter into the recovery phase. And this critical phase, first laboratory parameter changes are, that means there is a decrease amount of platelets. So platelet getting decreasing and the hematocrit getting rising. So there is a hematocrit is getting increased and the platelet getting raised. But if there is severe bleeding, then hematocrit can also getting decreased. So if a patient having dengue, which is present with shock and the hematocrit is getting up, that means there is a leaky blood vessels, and so we have to give more amount of fluid. But if the patient is in shock but the hematocrit getting decreased, that means there is a bleeding, so we have to give PRVC. So this is the main difference between the treatment protocol in dengue fever. So if the hematocrit is very much important. So if the hematocrit getting up, that means the fluid is getting leaky. If the hematocrit getting decreased and the child is in shock, that means the blood also getting out, and that means there is a huge amount of bleeding. So we have to give PRVC. So in the recovery phase, all the leaky blood vessels is getting recovered and the leakiness is decreased. So the fluid is all again enter from the interstitial space to the blood vessels, and the pressure is getting recovered, and also the platelet getting higher up and the hematocrit is getting decreased. So that means the recovery phase is, the child is in recovery phase, and also the immunoglobulin level is getting higher up. So for this we have to do IgG or IgM test. So this is the 3 clinical phases of severe dengue. So you have to keep in mind that after fever subsided, for the next 48 hours is to 72 hours is very much crucial for any patient. So you have to monitor the patient on that period. Now, how do you differentiate between the compensatory shock or decompensatory shock? This is very much important, because if the patient enter into decompensatory shock and we cannot treat the patient during this compensatory shock phase, then the child will have some organ dysfunction. So we have to know what is the difference between compensatory shock and when this compensatory shock is enter into the decompensatory shock, that means the child having some organ problems. First is the sensorium, that means start from the head to toe end. So first the GCS, that means normal sensorium. In case of compensatory shock, the sensorium for compensatory shock may be normal or the child may be irritable, but for the decompensatory shock, the child is restless, the child is lethargic or comatose, or the child having some stupor. The CRT is prolonged for both the patient, but there is a mottling is seen in the compensatory shock. Now the extremities, both the extremities are cold, but there is a cold and clammy skin. That means the skin is tight enough in the compensatory shock. And the peripheral pulse for the compensatory shock is weak and thready pulse. But in decompensatory shock, the pulse may be absent or very feeble. So very much important to check the pulse always. In compensatory shock, the pulse volume is weak and thready, and the pulse is consistency is 3D and the pulse volume is weak, but it is there. But in case of decompensatory shock, you may found that there is no pulse or very feeble pulse. You cannot many times you cannot feel that the pulse is not there. So very much important, if you feel the pulse is not there, that means the patient enter into decompensatory shock. The heart rate is both the cases there is a tachycardia due to the compensatory mechanism. The blood pressure in compensatory shock, the blood pressure is maybe the systolic blood pressure is always just like normal or slightly decreased, but the diastolic blood pressure is raised. It is very much important to know. The systolic blood pressure is slightly decreased, or normal, but the diastolic pressure is always high. So if a patient having increased diastolic pressure with normal or low systolic pressure, think about the patient having compensatory shock. In case of decompensatory shock, there is a unrecordable BP. Why the diastolic pressure is high in compensatory shock? Because of the systemic sympathetic nerve stimulation. As the sympathetic nerve getting stimulated, and there is a peripheral constriction. There is a constriction, and due to the peripheral vascular constriction, the diastolic pressure getting up. Now the pulse pressure. The pulse pressure is narrow, and decompensation it is variable. It is narrow, just like urine output is also reduced, and anuria are reduced in both the cases. So the most important is the pulse volume and the BP. So always check the pulse volume, BP, and see the GCS of a patient. If the GCS and the patient having GCS is poor or irritable, and there is a mottling, and pulse volume is feeble and not found, that means the child is entered into decompensatory shock. That means the patient need some inotropes or rapid fluid bolus to make the patient survive, because in decompensator the organ dysfunction is 100%. So what do you mean by organ dysfunction in dengue fever? Start from the nervous system. That means there is a either encephalopathy, encephalitis, intracranial hemorrhage due to the decreased platelet, intracranial hemorrhage may be there, or there may be patient may present with dengue fever and after that Guillain-Barré. So this is organ dysfunction. Gastrointestinal system problem, just like that, maybe patient may present dengue fever may present with hepatic failure, acute pancreatitis, parotitis, or there may be patient of hepatitis. Kidney dysfunction, that may be patient may present with acute renal failure. Heart, the patient may present with myocarditis, just like other viral fever. Lung, the patient may present with ARDS because of the leaky blood vessels. The patient of the reticular system, the patient may present with ITP. Just dengue fever patient may present with ITP, or the patient may present with HLH, that means high ferritinemia, because of the cytokine storm. So these are the organ dysfunction in dengue patient. Now the warning sign. This is very much important in pediatrics population. What are the warning sign for the dengue patient? Why? What do you mean by warning sign? These signs are mainly very much important to know, because if the patient may present with any of this sign, then you have to hospitalize the child. That means the child is not well. That means the child is not managed in the home remedy basis. The child need to supervision, because the child may enter into severe dengue. So what are the warning sign? If any one of the warning sign is present, you must admit the child or hospitalize the child for monitorization. It is not mandatory that if a patient is present having any warning sign, that any one of the warning sign, and the patient must enter into the severe dengue. It is not like that. So warning sign may be present, but the patient may not enter into severe dengue fever. So what are the warning sign? Abdominal pain and tenderness. There is a persistent vomiting. There is a clinical fluid accumulation, that means ascites or serosities, that means pleural effusion. Mucosal bleeding, nose bleeding, mouth bleeding, parectal gum bleeding, just like bleeding. Lethargy or restless, and the child is unable to take food. Liver is enlarged, that means 2 centimeter, and there is a tender hepatomegaly, that means the patient having symptoms of right heart failure. And laboratory features is just like increased hematocrit, as I said, with decreased platelet. That means there is a rapid fluid loss is there, and there is a decreased hematocrit along with decreased platelet, and the child is entered into the shock. That means there is a rapid bleeding. So these are the 7 warning signs. So if any of the warning sign is positive, you have to hospitalize the child. Now, if you suspect a patient having dengue fever, then you have to confirm it by doing NS1 antigen test for first 5 days. For the first 5 days, the specific rate is 98%. So it is very much sensitive and specific. So NS1 antigen test for first 5 days if you suspect a patient having dengue fever. After 5 days, if you suspect if you suspect a patient having dengue fever, then we have to do dengue IgM test, not NS1, because in this after 5 days the viremia stage is decreased and the immunoglobulin production is there. So after 5 days, it is important to do dengue IgM. And CBC and hematocrit is very much important and routine investigation for dengue test. And what are the frequency of doing CBC hematocrit, I will discuss later on. And LFT is very much important to see any organ dysfunction and liver problem. Now the management part. As I say, dengue fever may present with 3 clinical scenarios. That means just like a viral fever, the patient may, just like a viral fever, may not have nothing problem, and the child having just myalgia for 1 day, and after that the child is recovered. That's asymptomatic. Then nothing to do. If the symptomatic without any warning sign, just like a normal viral fever, having 2 to 3 days of fever without any warning sign, and after that the fever is getting normal, and the child become normal and recovered well. That means there is nothing to do. That means dengue fever without warning. Give only paracetamol and nothing to do, and ORS and nothing to do. Dengue fever with warning sign, you have to hospitalize the child and treat according to management protocol, and I will discuss later on. And severe dengue, you have to admit the child in the PICU and you have to treat the child according to the shock, either the patient having compensatory shock or decompensatory shock. I will discuss later on. So, first is dengue fever with warning sign. As I said, if any one of the 7 warning sign is positive, then you have to hospitalize the child. So you have to admit the child, you have to give paracetamol to decrease the fever, you have to tell the mother to give plenty of fluid to the child. That means ORS is the fluid of choice. You have to tell the mother to give much more amount of ORS. If the child is not taking ORS well, then you have to give intravenous fluid, IV fluid, by doing the cannulation, and the fluid of choice is crystalloid, that means NS. You have to give NS at a rate of, this is the changes in new dengue protocol. In case of warning sign, you have to give fluid of 5 to 10 ml per kg. For the adult, it is 7 to 10, but in pediatric, it is 5 to 10 ml per kg over first 1 hour. For West Bengal, the government of India, it is said that it is 6 ml per kg. For all over India, it is 5 to 10 ml per kg for over 1 hour. After 1 hour, you have to check the hematocrit. So, before giving the fluid, you have to do one hematocrit, that means CBC with hematocrit. After 1 hour, you have to again do the hematocrit. If the hematocrit is getting decreased, that means the fluid you have to hematocrit is decreasing during this phase. That means there's no fluid leakage is there. You have give sufficient amount of fluid. Because of the leaky valve, leaky blood vessels, the fluid is getting out. So if the fluid is getting out, the hematocrit is getting up. So if we resuscitate the patient with a good food fluid, then the hematocrit getting decreased. So if the hematocrit getting decreased and the vital parameters getting improved, that means fluid infusion rate is good enough, and we have to decrease it to 5 ml per kg over next 1 hour, and after the 3 ml per kg per hour over the next 24 to 48 hours, based on the patient is taking fluid well. If the patient taking after 24 hours, if the patient taking fluid orally well, then we have to stop the giving IV fluid and we shift to oral fluid therapy. and we have to do hematocrit more frequently. How frequently I will discuss later on. If after 1 hour of giving the 5 to 10 ml per kg over 1 hour fluid therapy, if the hematocrit getting rising, that means getting up and up, that means fluid is not delivering well. So vital parameters do not show any improvement, and the hematocrit is getting up. That means much more fluid is needed to decreasing the shock. So that means we have to give fluid infusion rate, increasing the fluid infusion rate to 7 to 10 ml per kg over next hour. In case of if the child getting improved after 1 hour, the hematocrit getting decreased. That means we have to again shift to 5 ml per kg, and after that 3 ml per kg after 1 hour, and then rest for 24 hours to 48 hours. Or if the hematocrit is not getting decreasing, so we have to go for fluid infusion rate of 15 ml per kg over next 1 hour, that means third hour, and we treat the patient as severe dengue with compensatory shock. Now, severe dengue, as I say, those who have dengue fever and then progress to shock, the plasma leakage or organ dysfunction and severe bleeding, this patient is called severe dengue. So the definition is any dengue fever who having progress to shock due to plasma leakage and organ dysfunction, and there is a severe bleeding due to coagulopathy and thrombocytopenia, it is called severe dengue. And severe dengue patient is divided during the treatment part in two types. One is compensatory shock, one is decompensatory shock. In case of compensatory shock, we have to admit the child in PICU, as I said, and we have to give the NS bolus of 10 to 20 ml per kg over 1 hour. So first we have to give the bolus of 10 to 20 ml per kg over first 1 hour, and then assess the vital parameter. What are the vital parameter we have to assess? I will discuss later on. After assessment, if the hematocrit after 1 hour, we have to do the hematocrit. Hematocrit is the first laboratory finding, and all the other vital parameter is very much important. So if the hematocrit getting reduced, that means the fluid which is leaking from the blood vessels is resuscitated well with the external fluid. That means the hematocrit getting decreased and the vital parameters are getting improved. That means fluid resuscitation is well, and we have to decrease the fluid rate gradually with 5 to 7 ml per kg over 2 hours, then 3 to 5 ml per kg over 2 to 4 hours, and after that 3 ml per kg per hour over next 24 to 48 days. But if the hematocrit is getting up and the vital parameter is not improving, that means we have to give a second bolus dose of same 10 to 20 ml per kg over 1 hour, and again assess. After assessment, if the child is improved, then we go to again 5 to 7 ml per kg over 2 hours, then 3 ml to 5 ml per kg over 2 to 4 hours, and then 3 ml per kg over 24 to 48 hours. But if after 2 hours of these two bolus, the hematocrit is getting up, that means there is a either bleeding and there is a either problem of the shock is in, just like decompensatory shock, that means refractory shock, and we have to give third bolus dose and also give ionotropes. So we have to start ionotropes and also give a third bolus and manage according to decompensatory shock. So this is the algorithm. Dengue shock with dengue fever with severe dengue with shock. That means pressure is minimally low, hypotension, and hematocrit is high. Start with the NS bolus 10 to 20 ml per kg over 1 hour. The improvement, that means the vital parameters are BP, pulse pressure. The laboratory parameters is hematocrit. The vital parameters is urine output, capillary refill time, pulse rate. So these are the vital parameters. If these are improved and hematocrit is decreased, then we decrease the fluid rate to 5 to 7 ml per kg per hours over 1 to 2 hours, then 3 to 5 ml per kg per hour over 2 to 4 hours, then 3 ml per kg per hour for the next 24 to 48 hours. But if there is no improvement and hematocrit getting up and up, so we have to give again fluid bolus. But if the hematocrit getting decreased and the child is not improving, that means hematocrit is getting decreased but child is not improving, that means there is a severe bleeding. So hematocrit is decreasing due to either fluid is very much well resuscitated by the external fluid, but either this hematocrit may decreased or the hematocrit is decreased due to massive bleeding. If the bleeding is massive, that means the RBC is getting released from the blood vessels out, then the hematocrit is also getting decreased. So if the parameters are not improving and the child having decreased hematocrit, that means severe bleeding, and we have to do blood transfusion. PRBC at a dose of 5 ml per kg. Now, if the hematocrit getting up and the vital parameters is not showing improvement, then we have to give the second bolus. After second bolus, we again check the vital parameters and also the hematocrit. If the hematocrit is getting improved, then we decreasing at a rate of 7 to 10 ml, then 5 to 7, then 3 to 5, then 3. If it is not, then refractory shock, that means need ionotropes and manages decompensatory shock, what I will discuss later. Now, the decompensatory shock, that means the child have to admit in PICU. First is the bolus is given within 15 to 30 minutes. This is the new changes. This is the second new change is the bolus should be given for decompensatory shock within 15 to 20 minutes at a rate of 20 ml per kg and then assess. So for previously it is after 1 hour we have to assess. Now it is after 15 to 30 minutes after giving the first bolus dose. If there is improvement is not there, then we have to give again a second bolus dose over 20 to 30 minutes and assess. But if the improvement is there and the vital parameter is getting improved and also and the hematocrit is getting up, hematocrit is getting down, and then we reduce the fluid rate to 10 ml per kg over 1 hour, next 1 hour, then 5 to 7 ml per kg over 1 to 2 hours, then 3 to 5 ml per kg over 2 to 4 hours, then 3 ml per kg over next 20 to 24 to 48 hours. But after the second bolus dose, if there is no improvement, then we give again the third dose of bolus within 30 minutes, and again when we have to start ionotropes, as because this is a refractory shock and the ionotrope of choice is adrenaline. So this is the algorithm. Decompensatory shock, we have to give a rapid bolus within 15 to 30 minutes. If there is improvement of the vital parameters, that means BP, pulse pressure, urine output, capillary fill time, pulse rate, and the laboratory parameter hematocrit getting decreased, then there is improvement is seen and the fluid rate is decreasing to 5 to 7 ml, then 3 to 5 ml, then 3 ml, and treat according to up to for 24 to 48 hours. If there is no improvement, then hematocrit is getting decreased, that means there is a massive bleeding. No improvement of the vital parameters, the hematocrit is getting decreased, that means there is a blood leakage and we have to give PRBC transfusion. If the child is virus parameter is not improving but the hematocrit is getting up also, that we have to give again a second bolus. So second bolus at a rate of same 10 to 20 ml per kg over next 15 to 30 minutes. After that, we have to check the vital parameters. If improved, then 10 ml per kg per hour for 1 to 2 hours, and then 5 to 7, then 3 to 5. If there is no improvement, that means the child is having cardiogenic shock and we have to give adrenaline as early as possible and the third dose. Now the vital indication of PRBC transfusion. When we have to give PRBC transfusion, if there is a severe blood loss, that means vital parameter is getting decreasing, but PRBC is hematocrit is also decreasing, that means there is severe bleeding, and we have to give PRBC. That means 10% or more blood loss, blood volume loss, and there is a refractory shock. This is the two indication we can give PRBC transfusion at a rate of 5 ml per kg. The platelet transfusion, platelet is not routinely given for the thrombocytopenia. When it is given, irrespective of bleeding present or not, it is less than 10,000. Without bleeding, we have to give platelet transfusion. Prolonged shock with coagulopathy, that means there is patient present severe dengue with shock, and there is a coagulopathy, that means gum bleeding is there or something, any bleeding is there along with the shock, then we have to give platelet transfusion. Now the monitoring, as I say, the laboratory parameter, that means platelet count. The laboratory parameter, the platelet count should be checked once a day till it should show a rising trend, and hematocrit is measured daily from the third day until temperature remain normal for 2 days. It is for the classic dengue fever or normal dengue patient. So for the normal dengue patient, we have to check platelet count once daily and hematocrit measurement daily from the third day until the temperature getting normal for 2 days and the platelet getting up. Now for the severe dengue fever, the vital parameters, as I said, heart rate, respiratory rate, blood pressure, urine output, and pulse pressure, we have to check every 30 minutes up to the child getting stable. After that, every 2 to 3 hours, as long as the child is in the PICU and on the hospital. So these are the vital monitoring for dengue fever. And hematocrit fast before giving the fluid. After that, after 1 hour of fluid, you have to check. And after that, if there is improvement, you have to check every 6 hourly till the patient is off from IV fluid. So this is the monitoring system. So this is for the dengue fever management. Thank you.